Hey everyone, welcome back to the Coding Coach. Thank you so much for joining. I appreciate all of the love that you guys been showing me on these videos, and I'm so glad that I am able to help you out during your coding journey, whether it's your journey to become a certified coder, or if you're already coding and you just need a better understanding of things. So thank you so much. And as I get into the video, I'm going to tell you, don't forget to like, to comment, and most importantly, don't forget to subscribe to the page. So today's video is going to be HCC information. We're going to talk about risk adjustment in chronic conditions. I know I have a lot of HCC videos, but HCC coding is very, very, very popular. So I have a lot of people requesting these videos. And each video, I try to break it down more and more for a better detailed understanding of HCC coding per category or per subject. So today we'll talk about a few chronic conditions, and I'll make another video going into more details about other chronic conditions. But a lot of people were saying that they were confused about the conditions that I'm going to go over today. So I wanted to make sure that I got a video out about that to make sure I help to clear up any confusion as a lot of people are going into the new year and they're testing this month and trying to go into the new year already certified. So I wanted to get this video out. Okay, so enough about that. So HCC information, let's go. Okay, so commonly missed chronic conditions. I wanted to go over a lot of chronic conditions that people normally miss when they're coding patient encounters. Sometimes they don't remember that it's a chronic condition. A lot of times people don't have the software there to tell them, hey, this is a HCC code. So I just want to go over a few commonly missed. These are the ones that are commonly missed in patient encounters. So our chronic conditions, even if they're stable, they should be assessed and captured at least every year, as well as each time a chronic condition has an impact on the diagnosis or treatment of an acute or other chronic condition. So let me go into detail a little bit where it says that it should be assessed and captured at least every year, as well as every time the condition has an impact. So let me tell you about that every year. And I'm sure if you're an HCC coder, you already know. So this is for people who don't know. Or there are some coders that I've spoken to who have been HCC coding for a while and didn't know this. So the term risk adjustment coding is coming from the fact that you're going to have a risk score. These patients whose chart we're coding for HCC companies and coding, they're having a risk score every year. So at the beginning of the year, it starts over, kind of like give them a clean slate. But a few things, and I'll go into a little bit more detail as the slides go on, but I wanted to stop here as, it was correlating with this slide. So a lot of conditions won't roll over to the new year, and a few do. So like I said, at the beginning of the year, you get a clean slate. But if you have HIV, if you have any amputations, if you're on dialysis, those things carry over to the new year with you. You don't get a clean slate with those. The score you have for that, it carries over. Everything else wipes out. You guys are asking me, where does the score come from? You get a score according to like your demographics, such as your age, your sex, whether you're a man or a woman. And then when you go to the doctor, every time you go to the hospital, whether it's the emergency room, your physician's office, when they diagnose you and treat you and see you, you're going to get a score according to what's wrong with you. And the score, it comes from the HCC categories. And it lets you know, the score that the patient is going to have. So throughout the year, every time the patient goes to the doctor, the hospital, or whatever, they're going to calculate or accumulate a score. And like I said, at the end of the year, going into the new year, wipes out for the new year. Some of these codes do not come up. So CMS made that a rule as far as, coming up with the score and, it's risk adjustment stuff. And I think it's actually a good idea. One thing about it, it stops fraud. Because think about this. So let's just say you have a patient that does not have a lot of things wrong with them, but you notice a doctor is ordering diagnostic tests, ordering radiology, ultrasounds, and just ordering up a whole lot of things for this patient. Well, if you have the risk score, which now we have in place, things like that, so you can look and say, well, hey, this patient is not a sick patient. You know, they hadn't been to the doctor a lot this year, blah, blah, blah. So why is this physician ordering all of these tests that the patient doesn't need? So the risk score and the model for that is very important. Okay, I always look for these conditions. And like I said, these are commonly missed chronic conditions. Amputations. So if you're reading a patient chart and you see they have an amputation, whether it's a toe, a leg, a finger, or arm, so you're always going to code the amputation. Always code the amputation. There is a code for it. Parkinson's disease. A lot of times this is missed. A lot of times coders don't realize that this is a HCC code. So make sure you gather Parkinson's. Rheumatoid arthritis. It's also a HCC code. More HCC codes here. We have alcohol and dependency. We have, make sure that you code organ transplant. You might be reading a chart and it says this patient had a kidney transplant. This patient had a heart transplant. Make sure you code the status of transplant. So ostomy. So here's a few conditions, chronic conditions that are missed that you can make sure that you look for. So non-specific documentation. So of course, in a perfect world, the doctor would document everything that they document, the specificity, you know, to make our job easier. But of course, like I said, there will be a perfect world and we do not live in one of those. So a lot of times the doctor does not get specific. And if it's not specific, you have to use a default code. You cannot code anything that's not there. You can't make up a code. You can't assume what the doctor is talking about. You have to code what's in the chart. So if it's not there, you cannot code it. Okay, so diagnoses that often default to unspecified due to the use of non-specific language. This is basically saying that when the doctor doesn't specify the type or go into the specificity of what's going on with this condition, then there's a default code. For example, if you see in the patient chart, the patient comes in, has diabetes and high blood pressure. Well, it doesn't say diabetes 1 or 2. So the default code per the guidelines is always assume and go ahead and code diabetes type 2. So here are diagnoses that often default to unspecified due to it not being specific in the documentation or in the chart. So arrhythmia. So arrhythmia, which is going to be I-49.9. So arrhythmia is the improper beating of your heart, whether it's irregular, too fast, or too slow. And cardiac arrhythmia occurs when the electrical impulses in the heart, they don't work properly. So there's types of arrhythmia. I'm sure you heard of AFib, which is atrial fibrillation, or atrial flutter, and also sick sinus syndrome. So if the doctor is not specific and they say in the chart, oh, this patient has arrhythmia, then you're just going to use the default code I-49.9. Then if you have one of these physicians who are on top of things, they know how to document properly, they want all of their reimbursement, they're going to make your job easier, they'll go into the type and they'll say AFib or A-flutter or a sick sinus syndrome, and that's even more specific. CKD, and I talk about this in a lot of videos too about being specific about this. If you just see CKD in the patient chart, the default code is N18.9. You're just going to automatically assume that it's going to be unspecified because you don't see it specified. There is not a stage, and here, let me go ahead and add it since I have it still up. There are 6 stages to CKD. So if it's not specified, then you're going to go ahead and use N18.9. If it's not saying whether it's stage 1 through 6, or if it's not saying ESRD, which is end-stage renal disease. Heart failure. So if it's not specified in the chart, again, if it just says the patient has heart failure, you're going to use I-50.9. But again, if you have a great physician who does amazing documentation, they're going to say the type. They're going to say whether it's systolic heart failure, diastolic, combined. And they'll say the severity. They'll say if it's acute, if it's chronic, if it's acute on chronic. So arthritis. Arthritis is another one that you have to be specific because there's different kinds of arthritis. And with HCC, if you do not specify the kind of arthritis, it doesn't have a HCC score, because rheumatoid arthritis is the only one of arthritis that rafts to a score. So there are different types of arthritis, and we talked about that in another video about the specificity, getting down to the specifics of what this person has. So here's rheumatoid arthritis. They can have that. So they can have degenerative arthritis, inflammatory arthritis, like sclerosis, sclerosic arthritis. So there's different kind of arthritis that a patient can have. So you have to be specific. Okay, so the default diagnosis code continued. We'll talk about depression because you'll see that a lot. You'll see depression and there's a default code. They have to explain the type of depression. Is it situational? Was it a situation that caused this depression right then? Major depression. Is it manic depression? Are you having manic episodes, psychotic things going on with your depression? Is it seasonal? Do you get depressed in the summertime or the wintertime because it gets dark early? You know, I've heard a lot of people get depressed when it gets dark early, or if you already have depression, it deepens it. Also going to the type, is it severe? Major depression, also, the episode is important. Was this just one time? Was it a single episode? Or is it recurrent? Do you have depression all the time? Also, as far as the severity, in addition to the episode, the type, the episode, and the severity, is it mild? Is it moderate? Is it severe? Is it in remission? Or is it unspecified? So if it's going to be unspecified, the default code is going to be F32.9. I want you guys to write that down. If you see depression in a chart and it's not specified, it just says depression. It's going to be F as in Frank, 32.9. I'll give you a minute to write it down. Okay, so atherosclerosis, the location, they want you to be specific. Is it a coronary artery? Is it in the extremities? Aorta? Be specific. Okay, I wanted to kind of, let's pretend we got a patient chart in front of us. A lot of people are in their coding journey, hasn't coded a chart before, don't know what a chart look like, you know what I'm saying, doesn't know what it look like or anything like this. So let's pretend we're coding a chart with sick-sinus syndrome, and I'll just show you one with the proper documentation as to how it's supposed to look and what codes you're going to use. That's what the point of this channel is, to get you practicing coding so you can pass this exam, and so when you get certified, you'll already know a lot of things in addition to what you've learned in class. Okay. So I've did a lot of abbreviations in here as well, because you'll see that on a lot of patient charts. So the patient comes in for follow-up for CAD, this coronary artery disease, HTN, which is hypertension, and SSS, which is sick sinus syndrome. And when you see the SP like this, that is status post, which means this is after something has been done or after the condition or whatever. So the patient comes in for a follow-up for CAD, hypertension, and sick sinus syndrome, status post a pacemaker, which means it just got a, they're coming in after they had a pacemaker in. Their blood pressure is 140/80. So they got a physical exam as well. Cardiac heart, regular rate and rhythm. The physician does an interrogation of the pacemaker. It checks it out, makes sure everything's good. The pacemaker is working properly. So now the physician is assessing the patient. So here I come in as the coder. Let me read the assessment so I'll know what the code. Okay. So the physician is saying the hypertension stable on lisinopril, that's I-10. CAD is stable, continue low-fat diet, this I-25.10. In the sick sinus syndrome, pacemaker fully functional, I-49.5. You'll notice anything dealing with hypertension, your heart, things like that is going to be in the I category. Like vascular, like if you have vein problems, I think that's going to be in the I category. Because it all goes back to your circulation, which goes to any hypertension problem. Okay, diabetes and ICD-10, CM, accurate code captured. I always go back to diabetes because diabetes categories are so large. Diabetes affects a lot of things. It affects your kidneys, it affects your heart, it affects your eyes. So there are a lot of combination codes in the diabetes category. So I like to make sure I always go over diabetes and things like that because there's so many. And I want you to just really get the gist, get the gist of understanding of how diabetes coding goes. So I put this little picture here because I'm sure if you don't yourself or you pretty much know someone who has diabetes and has this little glucose machine to check their blood sugar. So additional coding, let me tell you something. Let me help you understand something because this is so important. If you do not do this, the chart is coded wrong and it will be an error and counted against your accuracy. Okay, so additional coding. Let me tell you about additional coding with diabetes. Okay, so listen, diabetic ulcer. If the patient has a diabetic ulcer, this will require a second code to identify the site, the laterality, and the severity of the ulcer. So let me tell you, let me show you. Okay, let's say if in the patient chart it says the patient has diabetes type 2 with the foot ulcer. So I already know I'm going to code E11621 because that's diabetes type 2 with the foot ulcer. So when I say additional coding, I need to know the site, the laterality, and the severity of the ulcer. And remember, if it's not there, you can always use unspecified, but I still need you to use this code, this L code, letting me know that this person has an ulcer and the severity, the laterality, and the site is not specified. So let's say it was specified. So let's say they had a pressure ulcer, the left heel, stage 3. Bam, I use L89, 623. So whenever you're going to use that ulcer, make sure you also code the ulcer for the site, laterality, and the severity of the ulcer. So another additional coding, CKD. Diabetic chronic kidney disease will require a second code to identify the stage of the CKD. So if you're reading in the patient chart and it says the patient has diabetes, which has affected their kidneys, and they have stage 5 kidney disease. So you're going to code E1122, that's diabetes 2 with diabetic chronic kidney disease. And then you're going to code the stage of the CKD. You'll code N18.5, which shows the stage 5 CKD. So let's talk about major depressive disorder. I talked about it a little bit earlier, but I'll talk about it in detail here. So required documentation. Again, documentation is very, very, very important. And I'm not sure if you guys know or not, there is a very, very, very open lane for documentation coders. The certification is called the CP, I think it's Certified Professional Documentation Officer, CPDO or something, but it's a documentation certification. And I know a lot of coders who are loving just going behind doctors, looking over the documentation, things like that, and just to make sure that they're getting their maximum reimbursement by using the appropriate language when you're documenting. So Back to major depressive disorder, the required documentation. So like we talked about before, the episode, is it single or is it recurrent? Severity, is it mild, moderate, severe, in remission, or unspecified? Treatment includes, remember I talked about before in another video where medication can be supported, can support the diagnosis or the condition. So treatment includes medication, therapy, monitoring for stability of the depression. So if you see, depression and it's not otherwise specified, you're going to use, like I said, F32.9. And remission is further specified as partial or full. So if it's in remission, you're going to specify whether it's in partial remission or full remission. You see how it goes all the way down the line, and it gets more specific and more specific and more specific. So without specification of the episode and severity of the major depressive disorder, the complexity of the diagnosis is not represented, and it does not capture the complete diagnosis. And another thing, if you see anxiety with depression or anxiety and depression, then you're going to use the code F41.8. So this is another one. This is another subject I like to talk about a lot because people often get confused with this. And not only do they get confused, they leave a lot of codes out when they're coding CKD, hypertension, heart failure, because it's like a whole lot to take in. And so this is one of the things that you have to just over and over again just practice. And don't be scared to mess up. Don't be scared to make errors and things like that. Coders, I mean, you're not 100% perfect. And I know in a lot of production environments, they want you to have like at least a 95 or 96% accuracy, but that'll come with time. That'll come with time, with practice, and just on-the-job training of trial and error of learning. So hypertensive heart with heart failure and CKD. I had to take a side. Look at all this stuff going on. You got hypertension, and then hypertension is affecting your heart. Then it made your heart fail. And then you got chronic kidney disease. Oh, So let's pretend that we have a chart. And let's say that this is the clinical impression that the physician diagnosed this patient with. Okay. So the physician said this patient has hypertensive heart disease with acute systolic chronic heart failure and CKD stage 4. Okay. So I took some notes here. So let me just go through my notes just in case I need them. Okay, so I-13 dot whatever. So if you just pull up I-13, and if you have your book, you can, follow along with me. If you have any software you're on your computer, you can pull it up. Another site, it's kind of like an unofficial site, but I like to use it because it breaks a lot of things down when I'm looking for coding. I like the coding site ICD data. No, it's ICD10data.com. I really, 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 really like this site. So grab your books so you can follow along with me. Okay, you ready? So we got the clinical impression. We have someone with hypertensive heart disease with acute systolic chronic heart failure and CKD stage 4. Hope you know your Roman numerals. Okay, so I-13 dot whatever. So you pull up I-13 as I was saying, then you're gonna get hypertensive heart disease and CKD. Okay, so the first 3 characters, which are 1, 2, 3, the I, the 1, the 3, the first 3 characters indicate the category of the condition. So when you see I-13, you already know it's going to be hypertensive heart disease and CKD. Says nothing about the heart failure yet. So then you're going to come down here, I-13.0. And this is hypertensive heart disease with heart failure and CKD stage 1 through 4 or unspecified. So let me break this down for you. So once you add the heart failure into it, then you're going to go I13.0. And then this is heart failure in CKD. Now this is only for patients who have stages 1 through 5. If they have 1 through 5, or if the stage is unspecified in the chart, then you're going to use I13.0. And the fourth character indicates with heart failure in CKD. Fourth character, 1, 2, 3, O. The fourth character is the O. And it indicates with heart failure in CKD. And you see here, there's just 3 characters. It don't say heart failure. This one, heart failure in CKD. The range of the CKD. So continue with the clinical impression. So we have heart failure, right? You remember we got hypertensive heart with heart failure and CKD. So we also have to code the heart failure. So I-50, heart failure, the first 3 characters of here indicate the category of the condition, which is heart failure. You pull up I-50, this is what you'll get. And like I spoke earlier, if it was unspecified, you're going to use I-50.9. But here it's specifying, it said this patient has acute systolic congestive heart failure. So I-50.2 is systolic heart failure. And the fourth character indicates the type of heart failure, which is systolic. So I-50.21, which is acute systolic heart failure. And this fifth character indicates further specificity of the severity, acute or chronic. So now we have to code the stage of the CKD. I'll go back here, hypertensive heart with heart failure CKD. And remember here we have hypertensive heart disease with acute systolic congestive heart failure and CKD stage 4. We've coded, or we've looked at the I-13, which is the heart failure, which is the hypertensive heart disease, CKD with the heart failure. So let's go and code the stage of the chronic kidney disease. N18, which is the first 3 characters, indicate the category of the condition. And this patient has stage 4, so it's going to be N18.4, CKD stage 4. So if this was the actual chart, the codes will be I13.0, I50.21, N18.4. Okay, so let's talk about CVA. A lot of people say they get confused when they're coding strokes and CVA with HCC coding. So I wanted to add this because I don't have a video at all on this channel about CVA. Okay, so there are CVA, cerebral vascular accident, and that's basically a stroke. You know how we have different technical or medical terms, just like if you hear someone say myocardial infarction, that's a heart attack. So just like CVA or a cerebral vascular accident, stroke. So I'm not sure if you're aware, but there are three stroke types. You're gonna have ischemic stroke, and this clot is a occluding artery. Occluding artery, which it clogs it up. Intracerebral hemorrhage. Intracerebral hemorrhage. And that's bleeding in the brain. You know, hemorrhage means bleeding. So the next one, which is bleeding around the brain, this is going to be a subarachnoid. I always get it. I always pronounce this wrong. Subarachnoid hemorrhage, which is bleeding around the brain. Subarachnoid hemorrhage. Okay, acute stroke is only diagnosed in an acute setting. Frequent documentation and coding error. This is a frequent documentation and coding error. And what I mean by acute stroke is only diagnosed in an acute setting. When someone is realizing they're having a stroke, they normally go to an urgent care or the emergency room. That's an acute setting. Now, when you're following up, because think about it, and I got to hear, when you go to the doctor's office, it's usually to follow up and address any residual deficits of the stroke that you had, anything that's going on after. You know how you go to the emergency room or the urgent care and they tell you to follow up with your primary care physician. Because when having the stroke, like I said before, you're going to go to the ER or the urgent care. You're not going to wait to make a doctor's appointment, especially if your doctor is closed and it's at nighttime. So the documentation to support it, you might see it says personal history of a TIA. That's going to be very important to be familiar. Look up TIA. If you're not familiar with what a TIA is, I'll give you some homework. Look up TIA. And I think the code for that is G45.9. I bet it is. I can bet my bottom dollar on it just about. And if I'm wrong, make sure you put it in the comment because I'm not looking at my book right now. Okay, so the documentation to support, you're going to have personal history of TIA or stroke without residual deficits. Or it's going to say late effects, which includes cognitive deficits, monoplegia of lower limb, which is going to be left or right. You're going to have monoplegia of your upper limb, left or right. You're going to have hemiplegia, paresis, left or right. Any kind of other paralytic syndrome. Other late effects of the cerebrovascular disease, and any speech and language deficits. Okay, so if all those words sound foreign to you, monoplegia, hemiplegia, paralytic syndrome, all of this. So I broke it down even more, even more detail for you. Residual deficits of a stroke. So hemiplegia is one side of the body is affected. The arm is usually more involved than the leg. So it's one side of the body affected. So diplegia, all four limbs are affected. Both legs are more affected than the arms. Quadriplegia, all four limbs are involved equally. Monoplegia, only one limb is affected, usually an arm. Triplegia, 3 limbs are usually affected, usually both arms and a leg. And you see why it's going to be important? So for us to know which side, which arm, it's going to be very important. So here's examples. Left hemiplegia due to a stroke. They may document it in that way. CVA, sequela, and if you're not sure what sequela is, we'll go over that a little in a few more slides. CVA, sequela, monoplegia, right arm, difficulty swallowing, or weakness. These are our late residual effects. So these three here are going to be very important to identify the dominant side for the code specificity. And what I mean, identify the dominant side, just like I spoke of the monoplegia of the lower or upper limb. Is it the right side? Is it the left side? Are you right-handed? So it'll be the dominant side. If you're left-handed, then that's going to be your dominant side. Your dominant side is which one you use the most. So we're going to have to identify the dominant side for the code specificity. And then we're going to provide the causal language linking stroke to the late effects. just like hemiplegia and paresis, or other paralytic syndrome, or speech and language deficits. Those are the causal, it has causal language that's linking the stroke to the late effect. And lastly, the weakness due to CVA should be coded as hemiparesis or hemiplegia due to CVA. So coding residual or sequela effects. So a late effect is the residual effect after the acute phase of an illness has been terminated. There is no limit of when a late effect code can be used, meaning that if you have become paralyzed after this stroke, if 2 years later or 10 years later, you're still having late effects or you're still having issues due to this stroke, then you can still code it. Late effect must be linked by the provider to the illness that caused the residual condition. Like we said, stroke due to CVA, or CVA, excuse me, in the previous slide. So here I got another example, left-sided paralysis due to previous CVA. And that's what they mean here by late effect must be linked by the provider to the illness. This is linked because it said the left-sided paralysis, they're paralyzed because of a previous stroke. And their code is going to be I69.354. So hemiplegia following cerebral infarction affecting late non-dominant side. And so we've determined that this is the non-dominant side. So this is hemiplegia following cerebral infarction affecting the left, which is this person's non-dominant side. And this is the code. So thank you so much for joining me. As you can see, I didn't bore you guys to death. Oh, you hear my heater coming on. So hey, right at the end of the video. So thank you so much for joining me. I am so glad I'm able to kind of reach you guys and help you with these videos along on your journey. Don't forget to drop your questions down in the comment section. If you would like to see different videos, whatever you need help with, let me know what videos you want to see, and I can create your video to give you a better understanding of what you don't understand. I've been coding for about maybe 6 years now. I've been in the healthcare field as a whole for about 15 years. So I have a lot of medical experience, and if I don't know, I'm willing to learn. I have a lot of colleagues that I network with. So I'm sure if I don't know the answer, I can definitely get the answer for you. Because one thing about it, if I don't know it, I'm not going to act like I know. I am not afraid to ask for help. And we're all here to learn from each other. So if some things you wanted me to include or some things you might think that's helpful that I could have added to these videos, I'm more than open and I'm welcoming suggestions. We're all a community of coders that's trying to just help each other understand and just help each other grow in our craft. So again, thank you so much for joining me. And don't forget to like, again, comment, and subscribe. See you guys later.